public. And I would particularly like to welcome Rima Makram, who's the Integrated Care System Chair. She'll be talking to us later on under the agenda. And also I'd like to welcome our new governors, who again, I will also be mentioning a bit further on the agenda. So any apologies at all? Kwame, have you got any?
No, I haven't.
No. Okay. Thank you very much. And has anybody got declarations of interest at all in terms of their papers today? No, can't see any. Thank you very much. And just going on to the minutes from the last Council of Governors meeting back in July. Hopefully everybody's had a chance to look through them. Can I ask if there are any corrections or inaccuracies anybody spotted that we need to pick up on? Otherwise, we will approve those. Okay, thank you very much. That's great. Those are approved. And then going on to the action log, we have a number are due for January and some have been completed. I'll just go through the ones I've highlighted. Number 3, and that's the report on the Council of Governors evaluation exercise. That's coming back in January, I think, isn't it, Kwame? If I remember rightly.
Number 3.
Number 3. Sorry, that's the report on the Council of Governors evaluation. I think it's coming back in the January meeting. Is that right?
No, the action was on the number 3. The action was on the timetable for when the review of the Constitution will restart.
Yeah, I think the Constitution would restart. I beg your pardon, because we're reviewing it at the moment, and then that's coming back into the January meeting.
So there will be a subsequent meeting in January. Yes.
Yeah. Okay. Thank you very much. Item 8, that's on the agenda. That's other providers liaising with NHSP, NHS providers. Yeah. We have that on the agenda. And then item 11, that's also on the agenda.
Yeah, that's on the agenda. Yes.
Yeah, and item 13, we have Rima here today to give us an update from the Integrated Care System. So we said that we would pick up this action once we've had a chance to hear from Rima and to speak with her. So I think that covers everything, unless anybody has spotted something that I need to pick up. I don't think so. No. Okay.
No.
Kwame?
Yeah, it was item 12 on the action.
Item 12.
Yeah. To develop a presentation pack for governors.
Yes, that's coming back in January, isn't it? That's for January 22.
Yeah,
is that
so
right?
it is to be progressed as part of the engagement strategy that's on the agenda.
On the engagement strategy, yeah.
Yeah, what I wanted to expand slightly on that, if it's
okay, lovely, thanks.
Just to say that we want the governors to own this induction presentation pack. So after the meeting, I'll circulate the email address for Louis, who is leading on this. So if governors could go back to him and copy myself as to what they would like to have in a presentation pack. We want it to be compacted, not anything bulky. So what they would like to have in a presentation pack, so that it's not something that we get by with something that governors would like to have. Yeah.
Great. Okay. Thank you very much. Yeah. So that's true. We've been having discussions about streamlining it, haven't we? So that's really helpful. Yeah. So all of you would be very helpful if you wouldn't mind feeding back on that. That would be great.
Yeah.
Thank you very much.
So the email of Louis I'll circulate it so that people will have it. Yeah, and then be able to go back to it. Yeah.
Great.
Okay. Thank you.
Thanks, Kwame. Okay, moving on then. There's my report. Some of these things I must admit I've mentioned at board meetings, but I will go back over them as this meeting is only held once a quarter. But I took part in the Values in Action programme and Leading with Values over the last couple of months. I think it was back in July. I've met twice with the new chair of the urgent care services that are based on the hospital site. I've chaired a number of interview panels for consultants, and it's very encouraging, actually, the numbers of applicants that we're having and also the calibre of people. So that's a real positive. I continue to support the work of the Freedom to Speak Up meetings and the agenda there. We've actually had a board away day, getting to know each other a bit and doing some team development, which was really helpful because a number of us were new to the trust board earlier this year. The membership committee work for the members of the organisation is when the work's progressing well. And I think that when obviously there's more on the agenda today. I've continued with my visits as COVID allows, and been to the research and development department, which is doing some amazing work and has something like 4,000 participants with patients. It's quite extraordinary how much they get done. I also visited the mortuary team, and that was really interesting, particularly hearing about the time through COVID. And it's one of those services, obviously we all know it's there, but they carry on in the background, but they really are a very impressive team. I've been to the day surgery unit and also the hyperacute stroke services. I've been over to Whiston Gate to see colleagues there in IT, HR and procurement. Our Inclusion Leadership Council has now kicked off, and there's some very exciting work planned there. And obviously with the participation and input from our new equality, diversity and inclusion leads, Idris and Tim. Rima and I visited the Lakes Estate in Milton Keynes with Michael Bracey from the council, which was very interesting to see around the plans for refurbishment and regeneration in that area. So that was very interesting, and obviously it's something that all services are interested in supporting. Obviously we've had our constitutional review kicked off, and that will be carrying on in January at the next meeting. I think everything's been circulated. Kwame circulated everything, I know, for people to see after the initial meetings. We also had a development day for the integrated care system. That was very helpful, meeting colleagues across all sorts of sectors, not just health. So that was a really useful day to get to know each other better. We've had the Interfaith Week just last week, which was very interesting and really positive. There were some great displays from Denbigh School and Watling Academy. These from the children there who study there, and there was some fantastic work. Very strongly comes through the emphasis on kindness from children. I think that's a really positive thing, seeing young people bringing that through. And I know we're talking about membership and getting a broader sector of members, and it just seems the work that's going on with Sarah Crane and Amanda Pink in the chaplaincy is probably a really good opportunity for us to go into the schools, because they want to expand into other schools and get some young people as well involved as members. So I really look forward to that progressing. Now, I'd like now to officially welcome our new governors. We have Stevie Jones, Deborah Lewis, Martin Nevin and Shirley Moon. So welcome to you all. Absolutely delighted that you've taken on the roles. And as Kwame said, you know, we're hoping to get feedback as well around induction packs and everything from everybody. So we look forward to your input, and obviously on other items as well. So welcome, and hopefully I'll be catching up with you as soon as possible. I think I've still got a couple of governors to catch up with from the earlier elections this year, but I will do my best to get that done before Christmas. And the last thing I need to just update on in terms of the lead governor role, I'm absolutely delighted that Babs Lisgarden has agreed to put herself forward for the role. I've spoken with Kwame, and what we'd like to say is that we would like to propose, oh, somebody's waving. Oh, yeah. Robert? Sorry, you're on mute, Robert.
No, I just Barbara, she's waving back to say, come here.
Oh, right. Oh, sorry, I haven't got a picture of everybody. I beg your pardon. Thanks, Babs.
Sorry, Alison, that was me waving, because I'm delighted to see that this Babs has taken on the role.
Great.
And I'm here as I finished my governor role last night at 12 o'clock, and today I'm a member of the public. Lovely,
thanks. Well, thanks for coming along, Alan. But as I say, yeah, we're absolutely delighted. And but obviously we need to go through the formalities as well. So Kwame has asked if you could, is it to email you, Kwame, if governors would just email Kwame with their agreement for Babs to take up that role, please. And then we'll have done the proper sort of governance-y bit as well. But I'm really looking forward to working with with Babs. And Alan, once again, I know I've said a few times thank you, but again, once again, thank you very much. And I know you're going to be buddying with Babs and share all your experience. So thank you for that. That's great. Okay, so yes, and what in the next 48 hours, Kwame, should we ask if people could give their feedback? Would that be helpful? Yeah.
Yes, please. Yes, please. Yeah.
Great. Okay, thank you very much, and welcome on board, Babs. I'll be catching up with you soon. Now, I'd just like to hand over to Joe with the Chief Executive's report. I'm sure there's probably plenty to cover. Over to you, Joe.
Thank you very much, Alison. If I can start by saying performance-wise, we continue to keep our head just above water in relation to the pressures on the organisation. We have seen the numbers of patients with COVID stabilise in the last couple of weeks. I know Ian's going to do a presentation on that and go into a bit more detail. We have unfortunately had to cancel some further planned elective procedures because of that pressure, but I'm pleased to say that we're back operating on electives again now, and we are, as I say, keeping our head above water. What was interesting was at the weekend I saw the national position for the NHS against the 4-hour target of patients waiting in the emergency department, and we were 15th nationally. So even though performance isn't what we would like it to be, clearly relative to the rest of the NHS, we are performing very well. Still lots that we can do and lots that we can improve on, but we are sort of top quartile, top decile on that, which is good news. I mentioned electives. The number of patients waiting over 52 weeks does unfortunately continue to go up as we see the pressures coming in with patients being referred in from primary care to have operations and to have outpatient procedures and outpatient appointments. We are running extra clinics, we are doing extra work, we are trying to ensure that we target both those that are patients that are clinically urgent as well as those that have waited the longest. It's going to be a long haul to get back to some form of equilibrium, but we are on the right track. I think the key for us now is how do we prepare for winter? How do we ensure that all of our staff have been appropriately vaccinated and received the booster, and that we have sufficient numbers of staff to open and manage the number of beds that we have got, and to cope with what we expect to be a very, very challenging winter. So a lot of our effort and focus is on how we keep the overall team MKUH morale up, how we make sure that we do everything that we can to look after the team, to make sure that they're in a position to look after our patients. So that's sort of operational performance. If I just mention a couple of other things, if I may, Alison, we have implemented phase C of our electronic patient record. I won't test you all by asking you what that means in real language. In reality, what it means now is that the only part of the organisation that is not completely digital is outpatients. So we now have paediatrics, theatres, ICU, all now on the electronic patient record, and that all went in without any major concerns at all, which is great. And interestingly, we had the director of innovation for the whole of the NHS come and spend a day with us on Friday, and he was very positive, very complimentary about the progress that we've made, not just as an organisation, but the work that we're doing with our council and community services, the work that we're doing to connect with our tertiary provider, Oxford, so that clinicians have got immediate access to all of the relevant clinical information that they require. So that was a very positive indeed. And we have also, since we last met, been celebrating various days through from the allied healthcare professionals and supporting that team, all the way through to being shortlisted at the Health Service Journal Awards, which is a big national, if you like, the trade magazine of the NHS, where we were nominated for the work that we've been doing with our healthcare support workers. I'll finish off by saying the final piece of recognition that we've had was from the NHS England board, where we were highlighted as one of the exemplar organisations for developing the green agenda, and the work that we've been doing both with the whole of the team at MK, but also things like the solar panels and sustainable energy work that we've been doing. So that was mentioned at the NHS England board, which is great to hear, because that is an agenda that's obviously been front and centre in the media over the last couple of weeks. But I'll pause there, Alison, and take any questions at all on what I've said so far.
Thank you very much. Thanks, Joe. Alan.
Yes, Joe, when do you expect outpatients to join the electronic patient record?
What we have got is, sorry, there's a bit of an echo on the line. What we've got is the technology in place such that clinicians can dictate live in outpatients straight into the medical record. What we've obviously also got is some of our early adopters already doing that, but we do want to go through a very structured training program with any clinician that works in outpatients to make sure that they understand the technology, are trained on it appropriately, and then we'll put in a plan to go live specialty by specialty over the early months of 2022. So my expectation is in the next 4 to 6 months we will be live across all of outpatients as well, which will be absolutely outstanding.
Great, thank you.
Thank you, Joe. Any other questions at all? No? Okay, thank you very much. Thanks, Joe. Thanks for the update.
I think a couple of people have raised their hand, Alison.
Oh, have they? Sorry, it's not coming on. Oh, Andy Riley.
Yeah, it's not a question, it's just a comment. You mentioned how busy the hospital is. I unfortunately had to go to A&E a couple of weeks ago, having had an accident, and I appreciate how busy everybody is, but I have to say that everyone I dealt with, and I was later admitted and spent a night on the ward, everyone I met, clinical staff, support staff, on A&E and on the ward, and subsequently in outpatients, everybody was absolutely brilliant. Everyone I dealt with, no matter how busy or stressed they seemed to be, they were empathetic, good-humoured, patient, and diligent, and I was enormously impressed.
That's really kind to hear. I think one of the things that we are really focused on now is in the meeting. It is one of those situations whereby every newspaper you pick up and every news channel you turn to is saying it's the worst it's ever been and it's going to get even worse. That's not great when you're coming into work as a band 5 nurse and it's sort of you're already at -3 before you've even started the day. So one of the tasks that we have as a senior leadership team, as the whole team at MKUH, is to recognise, yes, the NHS is in a challenging situation. Actually, the vast majority of the people that we look after are friends, family of the staff of the team that works in the hospital. So this is about us as a team, all 5,000 people, coming together and doing the very, very best that we can for all of the people that use our hospital, and almost despite what's going on in the rest of the NHS, we know we can get back on track. We know that we can do a great job, and what is every individual's part in doing that. So trying to lift people's heads and lift people's morale. But it's lovely to hear what you say about the treatment that you received, and long may that continue.
Thank you. Yes, that's really great to hear, actually, and it is certainly very challenging. So all credit to the staff for keeping that compassion there. And now I just want to double check, because I haven't got any more hands up. Can anybody see can see a hand before I move on. No? Good. Okay, that's safe now. That's marvellous. Thank you very much. And now we're just going on to the COVID update. Ian, can I hand over to you, please?
Thank you, Alison. Good afternoon, everybody. I've got a couple of, well, 5 or 6 slides, which I will show if I may. I'm hoping, Alison, you're the only face I can now see. Can you see some slides on your screen, or a slide? Perfect. So as I've done previously, just an update on what COVID looks like in Milton Keynes. I'm conscious everyone, when you're looking at the news every night, will have all the national numbers, but sometimes the local perspective is more difficult. So this is where we are as of this morning. So today in the hospital, we have 31 patients who've had a positive COVID swab either in the last 28 days or on the current admission. So for a small number of patients, they would have been with us for more than 28 days. So 31 patients, and the orange bars there show you which ward these patients are on, and they're quite widely distributed. Now that's a bit of a concern in terms of infection prevention and control. So if I then change that to just patients who've had a positive swab in the last 14 days, i.e. patients who are here because of their COVID largely, we're looking after those patients on ward 22, which is our dedicated infectious disease and COVID ward, and on the intensive care unit. And we've essentially generated a pathway whereby patients who require non-ventilation or the mask treatment can have that done on ward 22 with appropriately skilled and experienced doctors and nurses. So 10 patients there at the moment. If I look then at the number of positive inpatients at Milton Keynes, this graph you've seen before, it has wave 1 on the left-hand side, so Easter 2020, when obviously the whole country was in lockdown, and we had a peak of about 100 patients or 90 patients in the hospital. Wave 2 back in January, or last Christmas to January last year, was far more substantial for us as a hospital, as indeed it was regionally and nationally, a far larger number of cases and unfortunately deaths. We then had quite a quiet period, April through to about August 2021, and you'll see that since the summer, the third wave has been with us. Now this wave is hopefully, obviously it may not have finished yet, but hopefully this wave has a much lower peak than either the first or second wave, but it will have a much broader base. So we're going to be having a number of COVID cases in the hospital for a prolonged period of time. And if you look just where that red circle has appeared, so around about the half-term week, so 3 or 4 weeks ago now, things took a step up pretty quickly. We had to move from one ward, ward 22, to a second ward for patients with COVID, and there was some anxiety that that number would carry on going up, and it was an experience that was seen in Bedfordshire as well. Thankfully, that does seem to have stabilised, and 10 patients is a number we can cope with relatively well, while still keeping all those other services which are busy going. This is a depressing graph. So this is the number of deaths from COVID in the hospital, and these are patients who've had a swab taken on arrival in the hospital, so inpatients. The first wave back in 2020, 108 patients died in that first wave. Things were then pretty quiet until Christmas last year, and then 350 or thereabouts further patients dying at that point. And you'll see that in this third wave, the number of deaths unfortunately has been creeping up. So typically, we're not having days where we're having 10 or 12 patients die, which was the case in the middle of the second wave, but patients are still dying either of COVID or with COVID, and that is an important distinction. With the community prevalence of COVID, we have had patients presenting with other things entirely who just happen to have a positive swab, and COVID isn't the main feature of their presentation, but those patients would feature in both our local and importantly the national statistics for COVID deaths. We've previously talked about nosocomial COVID, which is when patients who are in the hospital get COVID whilst they're with us, and that's clearly something we are very, very keen to avoid. It's no great surprise that patients in hospital who are frail, who are inevitably in a relatively close environment, are at risk of getting COVID. And on these slides, you'll see the orange label, the orange bars here are patients who've been in hospital for 2 weeks by the time they got their first positive COVID swab. So patients who in the national definition have definitely acquired COVID in the hospital. And you'll see that over the course of the autumn, we've had a little bit more, but not any major outbreaks. There was one outbreak back in late September, but otherwise sporadic cases of hospital-acquired COVID infection, and the yellow ones, which are probable, may or may not be acquired in hospital. And then just saying, probably the final slide. So staff are encouraged to use lateral flow test twice a week, and the aim of this essentially is to identify particularly asymptomatic COVID cases, such that those staff don't need to be at work, i.e. aren't at work and don't run the risk of spreading COVID to others. This slide shows some data from our process. The government have made it slightly more challenging for us because a few months ago they said NHS staff needed to get hold of the lateral flow test through the national system and encourage staff to also report their results through the national system. So we now have this rather unfortunate hybrid where some people are reporting to our local trust system, others are reporting to the national system, and unsurprisingly those data sets never do meet. But for me the important thing on here is that 269 occasions staff had positive lateral flow tests, and that would have been the way in which they found out they had COVID and then avoided the workplace. So it's a useful tool in our arm. I'm very happy, Alison, to take any questions anybody might have.
Thank you very much, Ian. There is one, Naran, in the chat box has said, do you have COVID patients spread across wards or designated ward for COVID? And then also in terms of vaccinated and non-vaccinated staff, what is the ratio, and are there efforts being made to get non-vaccinated staff to take it?
Great, thank you, Alison. So firstly, that was the reason, and in terms of where the patients are, those patients who are here and we believe have infectious COVID are very much isolated on ward 22 or in the isolation area of the intensive care unit. So yes, they are kept separate. When patients are 3 or more weeks after their COVID, so and again, particularly patients who are frail or have other comorbidities who had a COVID swab earlier in their stay, those patients may be in other areas. We will, of course, see patients from time to time who are on the labour ward who are COVID positive, and we'll see children who are COVID positive. Very often that positive swab isn't particularly material to the reason they've presented, but when we've got a patient who's in with COVID, we are of course isolating them. In terms of vaccination, our vaccination rates are approximately 96-97%, and I say approximately because the denominator here is more difficult to spell out than you might imagine. So I could talk about this according to the full-time staff we have, the staff who work here and nowhere else. But if I then start talking about bank staff as well, so people who work occasional shifts for us, that makes the numbers very complicated indeed. But we're doing well. Clearly, with the government's recent statement around vaccination becoming compulsory for staff in post on the 1st of April 2022, that is very much focusing the minds of everybody. We've got some really interesting, so the data can be quite complicated in this area, and I found a number of doctors, for example, who we've been really struggling to find out whether they've had vaccination, and the key issue there is actually they've been vaccinated under a maiden name, and their NHS name is associated with their NHS number, and their health records are associated with that. They practice with us under the other way around. So the NHS records under a married name usually, whereas a professional name may be a maiden name, and just matching up those records is really quite difficult the way the national systems have been set up. So we're working through all of that, and we're confident that it will be very small numbers of staff who are truly resistant to vaccination, and clearly they and other NHS staff will be having conversations, and we'll see where that goes.
Thank you. Thanks, Ian. William.
Ian, do we have any appreciable anti-vax activity that is causing any problems on site, or is that something which isn't a major issue for us?
No, so nothing on site, and I'm not really aware of any staff members who one would describe as anti-vaxxers. We've got some staff who are hesitant about vaccines, but everybody seems willing to have a sensible, informed discussion, talk about evidence, etc. So yeah, I think the next step will be people like myself and Nikki having individualized conversations with some of those people who haven't been vaccinated to try and find out what it is that's at the root of that. But no anti-vaxxing in that sense.
Okay, thank you.
Great, thank you. And Robert Johnson-Taylor.
It's just a clarification. When you say people are vaccinated, do you mean just the first 2, or do you mean the 3rd shot? Because the word booster seems to have got misappropriated at times.
Yeah, so that's yet another challenge in that if I gave you a figure in terms of percentages, the goalposts keep on moving in terms of when people become due for their booster as well. In terms of what we've been reporting, it is those people who've had the full initial course. So in the case of adults, 2 doses. Clearly, internally, we're keeping a very close eye on the boosters as well. But for the 1st of April next year, the assumption would be you'd be regarded as vaccinated. You had 2 doses and you're less than 6 months out from that second. So the goalposts are moving.
Thank you. Thank you both. I can't see any other hands, so thank you for that, Ian. Thanks for the update very much. And I'll now moving on and welcome Rima, who's here as the chair from the Integrated Care System. And I know there's a presentation which I think Kwame has very kindly said he will load for you, Rima. So welcome, and thank you for making the time to come and see us.
Thank you, and thank you for inviting me. I've met a few of you in the past, but it's very nice to see you all. So for those who haven't met me, I've been chairing the ICS for about 18 months now, and have now been made the chair designate for the future Integrated Care Board, which I'll come on to and explain to you in the course of this presentation. Thank you. So I'll start off assuming that perhaps you've got differing levels of knowledge of what an integrated care system is, and start off by explaining a little bit more why the country's moved to these new systems. So if you go on to the next slide. When one thinks about the health and well-being of an individual or a community, actually their health and well-being is only influenced 20% of that is influenced by what the NHS does for them in terms of clinical care. The rest of their health and well-being is entirely dependent on their personal health behaviours, for example, smoking, how much they exercise, their alcohol intake. The socioeconomic factors around them, so their level of education, are they employed, do they feel safe in their communities, do they have support for families? Their built environment, so the quality of the environment that they live in, and the housing, so the pollution and the housing. And if, as a society, we're going to make any difference to communities in terms of their health and well-being, we need to be able to concentrate action on all fronts. So the NHS can only do some of it by itself. It actually needs to work with wider partners to be able to achieve better long-term health for our populations. And on the next slide, I came across this quote from Desmond Tutu on the internet, and it just felt so relevant to an ICS. There comes a point where we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in. And that really felt very true about what the NHS tries to do day in, day out, pull people out of the river. But what if we could stop them from becoming ill, or help them not become so ill that they need us on a regular basis? So on the next slide, the core purpose of an ICS, as described in the pending legislation, is fourfold. One is to improve the outcomes in population health and healthcare. The next is to tackle inequalities, and we've seen a lot of inequalities come to the fore throughout the pandemic. So those inequalities are inequalities in outcomes, experience and access. We also need to improve productivity and value for money across the public sector across which the ICS is working. And we need to help the NHS support broader social economic development. So integrated care systems are new partnerships between all the organisations that provide health and care across an area. And it needs to be designed so that we can coordinate those services and plan in a way that we will improve population health, and we can start to reduce those inequalities between different groups. So on the next slide, the vision for the ICS is to improve outcomes for patients and for people. This is not just patients, but we need to put all the residents, the patients and the carers at the heart of our work. We need to focus on helping people live longer and healthier lives. So that means increasing the number of years that people spend in good health. So the last 20 years of people's health, for example, can be spent in very different conditions of health, with big differences between the most affluent and the most deprived parts of society. And we also want to reduce the gap between the healthiest and the least healthy in our community. And by integrating systems, we can tailor personalised care, and we can reduce that complexity and confusion that all of us know exists for all of us actually who don't, whether or not you know how to navigate the system. There's an awful lot of complexity and confusion in trying to navigate the NHS, social care and other parts of these systems. And we need to shift the focus from ill health to well-being and prevention. And all organisations involved in this must take collective responsibility for improving the population health outcomes. We manage our collective resources and we deliver to the highest standards that we can. So what does this look like for BLMK? On the next slide, we came together as an integrated care system around a common vision. So the integrated care system, as you know, incorporates all NHS providers and BLMK. It incorporates the local authorities with their focus on social care, on housing, on education. It incorporates Health Watch, it incorporates primary care, it incorporates the voluntary sector and, of course, communities. And we've united around this common vision, which is to work with our population to optimise health and well-being, advance equalities in our communities and make the best use of our resources. And we've defined 5 very high-level strategic objectives for the ICS. The first is to start well. Every child has a strong, healthy start to life, which basically means that every child, clearly we want maternity health to be good, but we also want to make sure they have their immunisations, their screening, childhood diseases looked after, mental health in children and teenagers. But it also means, where are they living? What's their level of education? How are we supporting vulnerable families? Because a vulnerable family in crisis has an impact on the child's future. We want people to be able to live well. We've seen over the last 18 months that people have had to support themselves because the NHS hasn't always been able to look after them in the way that they have in the past. And now that they're engaged with their own health, how do we continue to support them so that we focus on that prevention agenda, but also for those with the long-term conditions, how do we help them keep themselves healthy and not fall into a crisis? Aging well. So, you know, people need to be able to age well. We need to have proactive interventions to help them stay healthy, independent, active, and not socially isolated. The fourth one is about growth. So how does every one of our organisations contribute to the economic growth of BLMK? How do we also all contribute towards the green agenda? And finally, the fifth one, reducing inequalities, runs through the first 4. But we've put it there just in case there are specific projects that wouldn't be picked up by the first 4. So in everything that we do, we would promote equalities in the health and well-being of our population. And the box at the bottom of the slide, these are underpinning what we're calling enablers that have to be done across the system. So the data and digital strategy, some of which Joe touched upon about your own hospital, but also how does that work across the NHS? How does that work between the NHS and the police and social care? How can we share data and analyse it in a way that helps us support our population? The workforce, both the health workforce and the care workforce, the ways of working together as a collaboration and a partnership, our estate strategy, communications, finance, operational and clinical excellence. On the next slide, so the key question, of course, that comes back over and over again is, what does the system do? How can the system know what happens at place level? Actually, it's about things starting from place. So in Bedfordshire and Milton Keynes, we have the 4 places that match the local authority footprints. They in turn will have different neighbourhoods with different needs. The ICS, as it says here, is based on the principle of subsidiarity. And that basically means that the 4 places need to look at their own population health data and identify those priority areas where their local populations need some form of intervention. And therefore, what do they do with, so what these places would do is say, okay, those 5 priorities that I've just taken you through, they're very high level. what does every child has a strong start to life mean for us in Milton Keynes? What does our population data look like? What do we want to really make a difference to? And that might look very different to the priorities in Luton or Bedford Borough. At the moment, there are new place-based partnerships forming, incorporating the NHS, local authorities, GPs, and primary care networks, Health Watch, community groups, the voluntary sector. And they're working on delivering a place-based strategy and a plan for delivering to that strategy. And over time, the plan is that the ICS that will receive the funds for the NHS will start to delegate functions and resources as these partnerships mature. And that last bullet point explains what I've just said, which is that the partnerships are quite a big grouping of stakeholders, each of which play a key role in the population's health and well-being. So we have been doing lots of things, and so the next couple of slides show some of our successes. So the next slide. This is an example of a mother who's 28. She's got 3 children. She was referred to the Integrated Community Services team because she had issues socially, financially, and also suffering from isolation. She was experiencing physical, mental, and sexual assault from her partner while living with her 3 children in a 2-bed flat. And as a consequence, she was obviously suffering from depression, self-harm, and low self-esteem. And this team worked together with the local council, with the school, the children and family practice, and the family were rehoused, and they were given ongoing support, including helping her to manage finances. And that allowed her to break this cycle that she was stuck in. She was supported to look for work and retrain, and was given access to talking therapies. And now the family is happy. She's with her children in their new home, and the children are still attending their old school. And wouldn't we like to see this replicated many times over across our communities? On the next slide is a Bedfordshire example, whereby Bedfordshire Hospitals has been working with East of England Ambulance, and what they've set up is that traditionally paramedics go and pick up somebody who's fallen over, an elderly person, and takes them straight to hospital, where it may or may not be the right place for them. Through this silver frailty line, what now happens is that they're able to call up the hospital and talk to the frailty team, and they get specialist clinical advice. And the frailty nurses will advise them on how to support the person in their home, or to fast track them straight to the hospital, but to a specialist frailty ward so that they don't have to sit in A&E, which of course is better for the patient because they're not in A&E, and it's also better for the services. And this particular service is being held up nationally as an example of clinical best practice. So again, this is an example here of NHS providers working well together to find a more streamlined way of looking after individuals in the right setting. Next slide. So I keep referring to the legislation. So many of you, if not all of you, will know that at the moment there is a proposal to make ICSs legal entities. Up till now, they've been coalitions of the willing, and in some parts of the country, less willing. However, this is now this legislation, if it's passed, the intention is that it is passed by Parliament and receives royal assent by the 31st of March, making ICSs around the country, there are 42 of them, legal entities. In doing so, all CCGs will be dissolved, and the staff within the CCGs will be absorbed into the ICSs. The place-based partnerships that I referred to earlier will be fully fledged in place, and we're supporting them at the moment to make sure that they're ready to take on their responsibilities from the 1st of April. And then there are a couple of acronyms there that I will come on to explaining, but there will be something called an ICP, or Integrated Care Partnership, and there will also be an Integrated Care Board established. So if we go on to the next slide, I'll explain what these new acronyms mean. Are you able to move on? Okay, thank you. So the ICS is an acronym, and I'm sorry that all these acronyms, which are not our choice, all sound the same, so it's going to get confusing for a while. ICSs are the partnership what we've had to date. They are supported by two things that absolutely every ICS has to have. One is the Integrated Care Partnership, and the other is the Integrated Care Board. The partnership is effectively quite similar to what we've got at the moment, which is the Partnership Board, where all partners come together to set the strategy for BLMK. That strategy will be driven by the needs of place, and place-based partnerships, that's that green part of the jigsaw, are also going to be working to set the strategy locally. So we're currently working on what this ICP might look like, but it's likely to do things such as discuss what do we have in common across the 4 places and might be best done once across the whole system. What areas are really knotty where people are getting stuck and might need some support? What population health metrics might we want to see a shift in over time? And they will hold, the ICP is likely to hold each of the delivering groupings to account to make sure that they are delivering on the strategy. The blue jigsaw piece is the Integrated Care Board. Because ICSs will be legal entities, they need a statutory board, and this statutory board will be responsible for delivering, for managing the NHS funds. It's really testing my memory, this. So it will be responsible for having regard to the strategy that's set by the ICP, but it will be managing the NHS funds. It is going to be given a lot of NHS England's current regulatory responsibility, so will need to constantly assure itself of the performance of individual NHS providers, making sure that they are meeting their operational and financial performance targets. But it's still based on the principle of subsidiarity. So, it will still be looking to the places, to supporting them, to devolving functions over time, and to making sure that the NHS is responding to the strategy that will really support the population. And then the last jigsaw piece here is the orange one, that's provider collaboratives. So in the legislation, it says that every acute and every mental health trust has to be part of a provider collaborative, which is different to a provider collaboration or a network. They're more formal structures, and it's about providers working together to be able to deliver services often across a wider geography than just place. So those collaboratives might straddle several places, they might straddle several ICSs, depending on what they're trying to deliver. On the next slide, this is just going back to that partnership, that setting strategy. We're still working on it, but we are not restricted in this particular partnership on numbers. So the plan is to have every partner there. So all the NHS trusts, all the local authorities, probably one PCN clinical director from each place, all 4 health watches that we have in BLMK, and then wider stakeholders, police, fire, education, etc. I won't read it all out to you, plus the directors of public health. And we have 2 of those in BLMK. On the next slide, it describes the Integrated Care Board. So you'll remember that this is the statutory board that we have to have. And these bullet points, and you have got these slides, so I won't read out every bullet point, but it essentially outlines the functions of the board, which is about making sure that we have a plan to meet the health needs of the population, that we're able to allocate our resources and make sure that we've got good joint working partnerships or arrangements with all NHS providers. We have collective accountability for the governance arrangements, and so on and so forth. On the next slide, we've just agreed our proposed membership for this board. This has been mandated, and we are pushing our luck by having a slightly bigger board. So we're hoping that NHS England will approve this, but the early indications are that they will. There will be an independent chair, and I have been appointed to that. We are currently out to recruit a minimum of 2 non-executive directors, 1 to chair the audit committee and 1 to chair the remuneration committee. But over time, we may appoint up to 4, depending on the skill sets that we might need to function well as a board. We will have 4 executive directors. Felicity Cox, who is currently the executive lead for the ICS, has just been announced as the CEO designate, and she will be out to recruit a director of finance, a medical director, and a chief nurse or nursing officer. In terms of partner members, the legislation requires us to have 1 from each of the categories that are listed here. So 1 from the NHS, 1 from primary care, and 1 from local authorities. These partner members are not there to represent their organisations, they're there to bring their sector knowledge. And this is a unitary board, so they will have individual legal responsibilities in the same way that your own board has and your own board members have. What we've agreed is that we will have at least 2 from the NHS, 1 from the Milton Keynes area and 1 from the Bedfordshire area, because there's no overlap in partners or providers, NHS providers. But should we end up with 2 individuals with knowledge from the same sector, then we've got a 3rd seat to make sure that we have the other sectors represented. We will have 3 primary care medical services providers, 2 of whom will be GPs, and the 3rd could be non-clinical, could be a pharmacist or a dentist or an ophthalmologist, but basically someone else that knows another part of primary care. And then 4 individuals from the local authorities. We're also allowed to have participants. They are the same as board members, but without a vote. We will have up to 2 associate non-executive directors so that we can develop a diverse pipeline of future non-exec directors. We'll have the 2 directors of public health, any other executive directors from the ICB who may be required for, depending on what's on the agenda, and 1 health watch person. The 4 health watchers have kindly agreed to club together and work out who to nominate on behalf of the 4 health watchers. So that's the dry part of the presentation, but just to give you a sense of where the legislation is taking us in terms of governance. If we move on to the next slide. So I think you'll all be interested in this because as governors, between you, you represent the public, patients, carers and staff. And it's obviously really important that we don't continue to do what we've traditionally done in the NHS. Quite often, I know there are plenty of examples where it's not the case, but we've often done things to people, and it's not always what the population would have chosen to have done for them. So it's really important that we start off with the population and its needs, and we need to have that constant interaction with them. So the next couple of slides were actually developed by a young person in a mental health service who described to us why they think that the current ways of doing things have not really worked for patients. So in consultation, you're doing 2. You're basically asking people to fill in surveys, attend meetings, and it's considered to be tokenistic because actually at the end of the day, people don't have the opportunity to influence the actual change that happens after the consultation. In co-design, it's much better. There is a genuine impact, but they're not involved in the whole process and they don't see the project from beginning to end. So this young person on the next slide describes true co-production, and you'll see from this Venn diagram that involves co-planning, co-designing, co-delivery and co-evaluating. Does this actually work for what patients, service users need? So this was quite a neat thing. So we are working quite hard on this. We're trying to, yeah, that's absolutely fine. You can go on to the next one. We're trying to basically use the levers that already exist across all our different partners. We know that all our partners do co-production to a certain extent. You have different groups between you. And so rather than reinvent the wheel, we're just trying to use what already exists to be able to work more closely with our communities. And that was a big success story during the COVID pandemic. And we want to continue using what we've learned from that experience to continue to build on it. By co-producing, we'll be able to achieve better outcomes, and we should be able to start reducing health inequalities. We know co-production is a core value in both the NHS and local government, and that's something we all agree on. And we want to make sure it's within our work. And even on those strategic priorities that I showed you earlier, there have been lots and lots of meetings with people with lived experience and other stakeholders to make sure that we have hit the right notes, that they feel that we're going in the right direction. And so this is an encouraging start for the ICS. On the next slide. So I wanted to focus a little bit more on what does this mean for a hospital and for their governors where their foundation trusts. I myself was on the board of a foundation trust, acute hospital, for 7 years. And on the left-hand side, you will recognise a lot of things that over the last few years, hospitals have been asked to look at. And I'm sure that very much like my old trust, you may well have seen pages of targets spanning 30, 40, 50 pages of targets. A lot of them about access, 4-hour waits, the RTT, the counsellor waits, trying to manage that demand at the A&E doors. So you put GPs at the hospital door, you might have mental health crisis teams in A&E. Discharge to assess, lots of buzzwords. These are all operational objectives. They are really important to make a hospital run smoothly. But actually, when you start from a hospital's perspective to look at the population's need, there are many, many more things that the hospitals need to be thinking about, many of which you already are. So don't feel that I'm saying that this is not what Milton Keynes Hospital is doing, but this is a general slide. So I talked about provider collaboratives. There are opportunities for hospitals to work with each other, perhaps reconfiguring services, perhaps putting centres of excellence on different sites, perhaps finding ways of sharing costs and becoming more efficient. But there are also provider collaboratives that span vertical, so working more closely with community health and mental health, keeping people in the community, doing things once, just tidying up the NHS house is a really good way to look at it. As I mentioned earlier, NHS organisations are anchor institutions. Those are defined as having very local interests, large employers, big impact on the local community. So as employers, what can be done to encourage children from deprived backgrounds to open their eyes to other careers, whether it's in health and care, giving them work experience in the finance department or in the communications department, giving them volunteering experience, helping them with their D.of.E. Duke of Edinburgh Award for those who may not have come across that. What can we do about the green agenda? And Joe mentioned earlier all the good things that you're already doing. You know, what can we do even more together? What can we do about local procurement? And so on and so forth. What about specialist advice and primary care? So that primary care is better equipped or can keep outpatients in the community and not bring them into the hospital. Remote monitoring, how can consultants check that their patients are still on the right track and not declining, and therefore prevent a future crisis that ends up with the patient in hospital? Treating the whole person versus body parts. The reason why I write that is because in all my years in the NHS, everybody talks about the body part, the bit of brain that's not working, the lung that needs treatment. But quite often people want to only go to the hospital once. If they're going to go in once, maybe their diabetes can be checked while they're in there. Maybe people can think about the mental health issues that are associated with long-term conditions, or the fact that people with mental health issues don't live as long as people without. And therefore we need to treat the whole person. Data analytics, we all sit on huge amounts of data, and a lot of acutes are already working, as I'm sure you probably are, with, for example, organisations such as Google, DeepMind, working on analytics that allow us to determine what those early warning signs are that somebody's about to deteriorate, working on inequalities. Identifying unmet need. So if somebody comes in and they've clearly got unmet social need, how do we make sure that social services are alerted, that they get the right housing, that they get to food banks? And even funding out of hospital innovations. A lot of hospitals are saying, well, you know, if we used our funds to support voluntary sector, maybe some programs of work with social care, we would be able to make a big impact on population health, and the long-term benefits for the hospital are managing that demand. And what does that mean for people as governors? So the next slide, I Googled it. quite frankly, I haven't seen the national policy. And the national policy that seems to be out there is basically nothing changes for governors. Governors still have the same role they had before, but there will be an addition, and apparently, and I haven't seen it, and if it's out, maybe you've seen it, but I couldn't find it. There is allegedly going to be an addendum to the Guide for Governors, and it will give additional guiding principles, which is for the governors to have a legal duty to represent the interests of members of the Foundation Trust and the public, which is wider than patients, and the public local to the trust or those from governors' own electorates, and to support collaboration and the delivery of better joined up care. And so therefore councils of governors are required to form a rounded view of interests of the public at large. So basically the role of governors doesn't change, but it just becomes broader. It doesn't think just about the hospital, it thinks about the hospital without walls. So final slide, you'll be pleased to hear. So this is the trick that every organisation needs to be able to pull off. How do you pull off balancing the interests of your individual organisation and the benefits of the system? How do you make those trade-offs when sometimes what's best for the system and the population may not always be in the best interests of the hospital? How do you focus on population health needs whilst also keeping an eye on those operational challenges, which probably feel very real at the moment, but you know the population health needs are long-term versus what we're hoping is short to medium-term crisis? How do you think more broadly from the perspective of the local citizens or patients that you represent and beyond the confines of the walls? How do you make sure you've got that voice of patients, carers and publics, and the public and staff and stakeholders, and the individual, and perhaps even you have individual skills, experience and networks that you would want to play into the ICS? And how do you support the hospital to play its full part in the local system as it's a key player in an anchor institution? And at that point, I will stop for questions. Thank you.
Thank you very much. Thank you for supplying the slides as well, which I know people will, I'm sure, will take some time to really digest. And perhaps, I mean, what I could say as well is obviously there may be questions that come out from later on after this meeting. So I mean, I'm just to say I'm very happy if people let me know, I can feed those back. But Rima, presumably they can contact the ICS directly as well, or use the public meetings that there are each month.
Absolutely.
That's great, thank you very much. Shirley Moon, your hand went up first.
Thanks. You mentioned about staff moving over if all this is agreed. So from the CCGs, will that just be 2Ping straight across?
Yes, it is.
Great. Okay.
It is. But what's also happening at the same time is a recognition that commissioning, as it used to happen, which was commissioning by activity volume, if you like, now needs to change. It's going to be commissioning for outcomes. So there is not just let's pick you up and put you in the organisation, but let's pick you up and put you in the organisation. Let's look at the function and how you do it today and how it might need to look differently in the future. And is your function best done across the whole system, or actually are you better off looking after, say, Milton Keynes or another place in the system and doing that function specifically for that place, because places need support. The idea is that the system, the things that need to happen across the system happen across the system, but then everything else is done by the places, and the places will need support. And that's what we're working on at the moment.
Okay, great. Thank you.
Thanks, Shirley. William.
Can I first of all thank you for such a comprehensive presentation. I think it's probably the first time all of us have, tried to find a way of kind of understanding a complex, scenario. I suppose where I want to come from is recognizing that this is all really positive, but within positives, there are challenges, particularly I think looking at trying to get different institutions to really collaborate, and clearly putting in place mechanisms to do that and various types of representations. But inevitably, institutions sometimes slip back into kind of prioritizing their own bits and talk about collaborating, and that can sometimes become quite token. So, hopefully that won't happen very much. But I guess what I'm wondering is, how do you find a way of, in a sense, overcoming those obstacles, that are created by those institutions, and create a scenario where people genuinely work together? I mean, one of the things you're talking about is, for example, is co-design and co-production, and you talk about tokenism. I think there's a huge hill to climb to get beyond tokenism.
So my honest answer is this is going to take time. This is required. People talk about this being a restructure of the NHS. I think it's a restructure of the mindset and the culture of the NHS. It's shifting from that ill health to looking and doing things within year, because budgets were always given for the year and then you worried about the following year. Actually, if you're looking after population health, we're not going to shift those metrics in a year. We're going to shift them in 5 years, maybe 10 years in some instances. And local authorities are used to thinking in that way. There is still an amount of suspicion between NHS and local authority, but actually the tone in the ICS has shifted hugely in the last year or year and a half. So I'm pretty optimistic. I think all of our NHS providers are in a really good place. We're all very strong. We're financially better generally than a lot of ICSs, and we have a lot of willingness around the table. So I think we'll get there. I think the pandemic isn't helping. I think that the pandemic, of course, as Joe described, is taking up a lot of people's mental health, their headspace, which is why we behind the scenes are trying to push through this other stuff to meet the legislation on time and get people trained up with everything in the right place to allow them that once hopefully we get through the winter to start re-engaging with the system. There is, some people say to me, but we can't do innovation right now. We just haven't got the time or the space. Actually, innovation could make things easier for people while they go through the crisis. Yeah. If we can alleviate some of the pressure by doing things a bit differently, then perhaps the people have more time and more space. So it's not always about the big bang approach. Sometimes it's about doing small things and doing the quick wins, doing that proof of concept. Because I believe that the more we do together, the more ambitious people are going to get, as people can start to go, actually, that wasn't so bad. I think part of the problem is also going from being autonomous to working in a collaboration is much harder. Yes. So the hospital I was at was UCLH, and this is the example I give, and it might give you all an example of how you might think about that balance between the hospital and the system. When I joined UCLH, their local academic health science network had just been brokering that UCLH would give up its heart hospital and give it to Barts, so another big hospital in East London, and in return it would be given cancer services from across North London. So on one hand that was quite nice because the hospital could reposition itself as a bit more of an expert in cancer, whilst Barts redefined its cardiology. The problem was that in those days, we're talking about 7, 8, 9 years ago, the problem was that cardiology in those days made a margin. Cancer was loss-making. Yeah. So financially, it was going to destabilize the hospital. So the conversation for the governors and the NEDs was, okay, we have to do this because it's much more beneficial for patients to have these centres of excellence, and it's better for North London if we agree to this, but how are we going to balance the books? So the conversation became about that. And I think that that's what happens in these collaborations, is that sometimes you have to give up something, and it then means you need something else to help that sustainability in the long term. And those are conversations will go round and round quite often, I think, over the next few years.
Okay, thank you.
Thank you very much. Joe, you'd like to come in?
Thanks, and apologies, my camera's not on. Just picking up on a couple of things that Reem has said, I think it's probably worth giving a real example of some of the local working that's going on. So we know that there are 17,000 type 2 diabetics in Milton Keynes. We're working with public health, with the council, with our primary care colleagues to see how we can use the data that we've got with the technology that is out there around remote monitoring, working with Apple, working with the Secretary of State's office to be innovative, to understand how we can better manage those individuals out of the hospital in a way that gets them fitter, gets them healthier, rewards that behaviour, and ultimately saves the NHS money on fixing those individuals when they become sick and making their quality of life significantly better. So in the nicest possible way, people don't have to come into the hospital. So that's a real live example of where we are, and the hospital is ultimately going to be sort of putting the money up front to do that, because we know that it's the right thing to do, and we know that ultimately it'll make it economically more sensible for the whole of the place. So that's a good example, I think, of where we're already looking and working outside of those hospital walls for a population that need input now to get them healthy and keep them healthy, to stop them having to use MKUH in the future in crisis. I think the other thing is, again, picking up on Rima's point about innovation, I think we're fortunate that we have a hospital that has and is innovative in its approach to so many different agendas, whether that's health and well-being, whether that's technology, whether that's the green agenda. So I think we're starting from a very positive place, and it's how do we ensure that everything that we do is focused not just on fixing sick people, but keeping people within Milton Keynes as a place healthy, not just today, tomorrow, this year, but over the next 10, 20 years. And that relationship with the council as they grow Milton Keynes and develop Milton Keynes is critical to ensuring that we play our part and that we don't just keep investing money in the same old thing. So I think from an internal perspective, I'm thinking I've got a team that, the team being the whole of MKUH, who are up for doing things differently, trying things, fail fast. I think the expression is, if you're gonna fail quickly, change it, try it again. And I think the board, the organisation has been very good at that. And I think we need to continue to foster that sort of innovation across what we do now, and then outside of walls across the place itself. My final thing is, I think we've got a brilliant tertiary centre in Oxford who are also doing some fantastic work. How do we bring some of that into the place, into the ICS, in a way that supports and benefits our population? There's no point in being a hospital succeeding if the population is getting sicker.
Yes, thanks for that, Joe. And I think, yeah, that your final point in particular, you just feel there is so much good stuff going on, and it's about sharing that across the system. I mean, obviously, I live over at the Bedfordshire side of BLMK, and you just feel that actually sharing, particularly some of the technology and that I've seen over at Milton Keynes, would just be great to have that rolled out. So that's a really positive sort of approach. But there is a lot of good stuff. I mean, both of you said, there's a lot of good stuff going on, and we need to build on that and share it as well. Alan Hancock.
Hi, Rima. Firstly, just to pick up on what was just been said about the sharing with other ICSs, I just would like to know how much thinking has gone into the actual question of sharing. I mean, the relationship with Oxford is obviously a major point as far as we are concerned. But in order to actually have an ICS which serves the needs of the population at a place level, a really close and to some extent formalised relationship with the next ICS, with Bob, is, I think, very important. The second question, you mentioned the guidance to trusts as far as constitutional arrangements are concerned. As Alison mentioned, we have a committee looking at the existing constitution, and I wondered to what extent this is guidance, or if it's going to include elements which are of a statutory nature and have to be incorporated, because it would affect the way in which we're able to make recommendations and get a draft going. The third question, are you confident that you'll meet the 1st of April deadline? And I wondered what the main barriers are likely to be to meeting that, because I know that a lot of ICSs are finding it very difficult to envisage that being finished by that date. Thank you.
So, all very good questions. We don't have a choice about 1st of April if it were to happen, and therefore we have to be ready. But ready means that we need to have our board established. We will have that. We, other than potentially we won't have all the executive directors in place. The reason why ICSs are struggling is because we've been stopped at each point by NHS England saying you have to wait for the guidance. And the guidance coming out next week. No, it's the week after. No, it's next month. And everything has slipped from the NHS England perspective, which makes it very difficult for us to have everything in place for the 1st of April. But I see the 1st of April, as I think we all do, as the start of the journey, not the end point. So we will have most things in place by then. I'm really hoping that we'll have sorted out the principles of our governance by then, because I think it's a major distraction at this point, and I'd rather be delivering things for the population. But it's what we've got to do at the moment, and we're working quite hard to get us there. In terms of, therefore, your constitution, my response is, like everything else, if we're waiting for national guidance, we're waiting for national guidance, and it's not something that's coming from us. So it'll be when it comes out, and if it comes out. So I would just continue doing what you're doing. You know more about the ICS now and what we're trying to achieve. And, you know, I welcome your contribution towards it. In terms of collaboration and learning with the other ICSs, absolutely. So lots and lots of things are going on. I spend half my life talking to other ICSs, to be honest. For example, normally every Monday evening, I'm in a meeting with my counterparts across the east of England. I am on a WhatsApp with all the chairs of all the ICSs across the country. I am on the NHS Confed Advisorate for ICSs, and so on and so forth. It's really important that we don't try and reinvent the wheel. I'm really keen to go out there and find really good examples of things that are working and just nick it and adapt it is my approach, because there's no point having 42 different approaches for the same problem if somebody's made it work. There are ICSs in the country that have been doing this for many years and are more advanced, and they tend to actually be in the north, but not only. And every ICS is different in the way that they look, for example. So some ICSs have one council, one health watch, and a very small set of providers. In some ways, that's easier. It may not be richer, but it's easier. Other places like Manchester have 13 councils. They're very different beasts, but the approach to population health will, you know, a good project is worth looking at in our system. Absolutely, we need to work with Bob. There is actually no intention to do anything that would endanger the relationship that Milton Keynes has with Oxford. And if anything, partly because of my background as a former scientist, I've been encouraging the ICS to look into becoming a research ICS. So not just having good research hospitals such as Milton Keynes, but actually providing the infrastructure, the support to get bids and to do the R&D across the whole system. Because every patient that's involved in some kind of R&D gets better care, because it helps us retain and recruit staff who want to be part of it. And they don't have to be doctors, they don't have to be nurses, they could be pharmacists or allied health professionals. And being in that centre between Oxford, Cambridge and London puts us in a fantastic geographical location to be attract over time lots more and more R&D.
Thank you very much. Thank you. Thanks, Rima, and thank you everybody for the questions and comments. I'm aware I've let this just run over very slightly because it was very interesting stuff, and it's great to have that amount of detail. So thank you, Rima. I'm sure there will be other questions coming as people digest it more. So I'm probably be bringing plenty back to you. But thank you anyway, everybody. I'll move on now to our next agenda item, and that's the Governor's membership and engagement strategy. And I think Kate, you're picking that up. Is that right?
I think Kate is on the call.
Ah.
So.
Right. So do we know who's going to pick this up then?
It falls to me.
Right. Thank you, Kwame. Over to you.
Okay. Okay, so this is a sort of a refresh of the old engagement strategy that we had, which ended in 2020. And this strategy will be, so we're looking at working with several stakeholders, including the diversity team, patient experience, the hospital charity, and the partnership organizations. So it will try to be widespread as possible, the people that will be supporting, we'll be working with. And this will be led by Louis Strakia, who is on the call. He's a communications expert, professional, so he'll give that professional impetus to make sure that this is truly embedded and truly delivered as it should be. We have a membership engagement group who will be monitoring the delivery of this strategy and making sure that the progress of it and the actions and everything that needs to be done is being reported to the Council of Governors. I assume that is read, but I'll provide a few pointers. One of the main things that the membership, the public membership of the trust is declining, and on the outline of the overall decline is set out there from 2015-16 till March 2020, 21. The end of 2020-21, we lost 300 members, and there were no members under 16 years and 20 members between the ages of 17 and 21. So that will be one of the targets, to reverse the decline and to try to make sure that it represents the demography of the city as much as possible, but not the other objective is to help to support the council, members of the council, so that they fulfill their remit, which is to represent the members, the voters, and the public as much as they should. Number 3, the point 3 is the sort of tools with which we will use to do the job. So through the trust website, we plan to also use various tools to conduct regular membership recruitment campaigns, a lot of social media work. So through the trust communications on social we're using it to promote membership, to use it to promote the news, all the various news items that come through. And one particular thing that we'll be looking to introduce will be youth and school events to try to balance the demography. The Louis and supported by myself and other governors will be going to schools and we'll be trying to reach out to the youth groups in the city. The other thing also, we'll be using the diversity team, equality and diversity team, to try to reach any other groups that are not easy to reach, basically. The 3B is where we'll be trying to support, and as I mentioned when we're going through the action log, membership and public engagement packs, which and all of it should be owned by basically the governors. So we'll be working to support, and we'll be trying to see whether we'll use modern social media tools for us to have constituency surgeries, and to have through that to also try to bring in outside people, maybe to give talks, and that's all. We are thinking through these things, how to proceed. So the objectives, to go to the objectives, the first one is to have a representative public membership, which reflects the communities that the hospital serves, and to try to raise the profile of governance for the public and for the staff, as well as staff governance, and maybe not to increase it too much, but to also try to see whether we will. Basically, the initial is to stop the decline in membership, and to support governance engagement with their constituents. In conclusion, is to basically have an engaged membership, that's and a membership that's representative. That's the two main objectives. And in the last line, the membership an engagement manager, who is Louis, will be developing an annual program of activities to support this strategy there. So I recommend it to council, the governors, to approve, and so that we can roll it out.
Thank you very much, Kwame. That was well covered. Thank you very much. Yeah, and certainly in terms of the schools, I mean, as I mentioned earlier, the work with Sarah and Amanda as well, the links that they have with the schools, I'm sure we can use those as well to add to our ambitions. Shirley.
Okay, sorry. Yeah, I actually used to be the apprenticeship manager in the trust, so I started doing schools outreach. And when we did try to do something about membership, the stuff that we'd got, the materials that we were trying to engage them with, didn't really suit that age group. So I think we need something that's a bit more appropriate for them and is a bit more geared towards people who are doing health and social care courses and, you know, or wanting to go on to do being a doctor or something, and you know why it's actually useful for them, and you know knowing about what goes on in the trust a bit more. So I think there needs to be a bit of work on that. So but I'm quite happy to get involved in that, and I'm sure Hannah Barnett, who took over from me as apprenticeship manager, will be quite keen to get involved in that as well.
That's brilliant. Thanks, Shirley. I was just going to say, are you volunteering? And you did it right at the end there. So thank you very much. No, that's great. You're absolutely right. And it is around, I mean, and reflecting back, you know, what Rima said is, you know, so much around working with people and actually, you know, producing stuff that's relevant and engages. So that would be great. Thank you for that. Claire.
I think it's important to get out to schools, and I'd be happy to help on that side, because I used to do quite a lot of talks to different groups and different age groups, and I used to sort of teach when I was younger in some areas. So I'd be quite interested. I think also you need to not only look at the people that might be interested in getting into the health sector as a profession, but you also need to get it in the point of view, well, you know, about your grandma or your mother or your father or somebody who's been ill or is not that well, and how you can engage them to actually get more into the engagement from that side, not just from whether you're going to become a professional, but just as a caring person. I think would be a good way of doing it as well. So I'd be quite interested in that side of things.
Great, thank you very much, Claire. So that's 2 names down, Kwame. I hope you've got those down. I'm sure Louis will be getting in touch.
Yeah, and as I said, we will be using a lot of stakeholder support. So anyone that will help to do any of it will be well appreciated, and it's owned by the governors as well. So yeah.
Absolutely, thank you. Yeah, no, that's great, and thank you for all the work on this as well. It's great to have it refreshed like this. It's here for approval, so perhaps can I just ask, unless anybody has any objections to approving it, I think that's probably the best way around. I'll look for any hands going up. I think, Claire, your hand is just an old hand. So if there are no other comments, thank you very much. We can say that's approved. Lovely. And we'll crack on with that and work with that going forward, and with Louis as well. Thank you. Thanks for that comment.
Yeah, thank you.
Next one's the Governor Induction. I know, again, that's got Kate's name down, but presumably it's fairly self-explanatory, and it's really just a question to ask governors to come back around the training, isn't it?
Yeah, and to come back to Julia by the 29th of November, please.
Yes, thanks. I'd forgotten there's a specific date. So yes, I mean, it gives an indication what's available. So if people could come back, that'd be great, because then we can get things organised and in the diaries. I think as well, I mean, it'd be useful to know as well. I think sometimes there is a question around times of these things, the timing of these things. Sometimes, you know, for those that work or have other commitments, sometimes the daytime stuff can be tricky. And we can always feed this back, I think, to NHS providers and others, actually, to try and encourage them to be more flexible around time. Perhaps we can do that as well.
We'll do that. Yeah.
Great. Okay. Thank you very much.
I think that was the idea. That was the idea in terms of the times, to see whether they could do something around the timings of it.
Yeah, absolutely. Absolutely. Great. Okay. Thank you very much. And now Health Watch. Have we got anything from Health Watch at all?
Yes, Here I am. Hi.
Ah.
Am I on the screen? Can you see me, Alison?
Maxine, great. Hi.
Hi. I submitted a short paper in advance of the meeting. I just want to highlight, put into context some of the things we put across in the briefing. We've had a bit of a declining amount of feedback coming directly from the hospital through patients over the coming months. I think perhaps that is indicative of continued support to the NHS, which is particularly reflected at secondary care in the public conscious in some ways. I think it also can be indicative that people are finding the right kind of support through PALS and an effective PALS system. It's quite in contrast to some of the other areas of health that we're hearing a lot about. So we're in daily contact with residents, in particular around access to primary care and the challenges of accessing primary care, as well as the challenges in accessing NHS dentistry. So those are two acute issues that residents are talking to us about quite on, like say, on a daily basis. Highlighted here is we have had a growing trend of a number of women contacting us, feeling that they have been suffering some kind of inequalities in their care and treatment, kind of an assumption when they're presenting issues that their needs or their symptoms aren't being taken seriously or being misdiagnosed, and that's perhaps causing delays in treatment and care. So we've heard that from a number of patients across health services. And as a drive towards improving insight around health inequalities, we're going to be doing some focused work on that over the coming months. That includes 1 or 2 listening events and potentially a larger health and wellbeing event that we're planning, putting it around the theme of women's health and supporting those things. So we're hoping that will provide some insight and see if that is something that we're just hearing about, or whether, you know, it's a common theme for the population of Milton Keynes. We have a new outreach worker in post. She started mid-October, so she's been very busy squirreling away, planning out our outreach and engagement events over the coming months. I will make sure that we circulate the leaflets of our events to the governors, because we are doing some we're doing a large health and wellbeing event in the Trinity Centre in Fishermead on the 3rd of December that you're all welcome to come to. So do pop down. There'll be lots of stalls and lots of advice and signposting information available to residents. We'll also be holding some drop-in listening events. Again, we're trying to tie in the theme around inequalities, really getting out there and listening to people, giving people the face-to-face opportunity to talk about what inequalities that they might experience, not just in health, but the wider determinants of health as well. And just to cover off there, that we have been in and around the hospital and urgent care over the last couple of weeks doing an audit of children's A&E and children coming to visit urgent care services. That has been enlightening. We've had really good staff engagement, particularly in children's A&E, and we've been speaking to the adults while we've been in and around the system as well. So hopefully lots of insight around why people are presenting at emergency care, and opportunities for the system to address some challenges for people in terms of access, particularly in primary care. So that's it from me.
Great, thank you very much, Maxine. That's really helpful. And it's interesting, you know, the sort of feedback you're saying you're having from women as well. I know there's the patient and family group meeting this week, and also we now have our Equality Inclusion Leadership Council, which is starting. It just seems to me that, you know, that it'd be interesting, you know, sort of closing the loop on some of this work, you know, feedback from you and obviously things coming through from our members of staff and other areas where we're linking up with partners. So I think that, yes, there's probably quite a rich discussion that can be had around those sorts of issues. So thank you for feeding back on that. Can I just ask if colleagues have any questions or comments at all for Maxine? No? Okay, thank you very much. Look forward to picking up on those things, Maxine. Thank you for that. Right, so I'm just checking my agenda. We've got to the point, any motions and questions from the Council of Governors at all? Is there anything that anybody wants to raise? I haven't had anything flagged up. I don't think Kwame has either. So no, I can't see any hands going up. So no. Okay, thank you very much for that. And is there any other business from anybody at all? Doesn't look like it. No. Okay. Well, thank you all for your time. It's great to see you all, and eventually, I'm sure we will be able to meet in person. This is the next best thing, and but I would like to say once again, thank you to Rima for her presentation, and everybody will be able to have a copy of that. And obviously, if there are other questions, please do come back. And obviously, we will update regularly as things progress. And also, finally, as well, just another warm welcome to our new governors, and look forward to working with you. So thank you for your time this evening, everybody, and look forward to seeing you again soon. Thanks.
Thank you.
Bye-bye.
Take care.
Bye.
Bye, everyone. Bye.